Hi, this is a continuation of our discussion on spinal cord injury. In this subtopic, we'll be talking about the acute complications and management of which. Okay. The first complication that we would like to discuss is your spinal shock. So we've mentioned about spinal shock, and you can recall that we have your bulbocavernosus reflex. Now let's try to understand spinal shock deeper. So when I say spinal shock, that would refer to temporary. Okay, the big word is temporary areflexia. Areflexia is the loss of your reflex function, obviously below the level of your injury. So it is an immediate response or immediately happens to your spinal cord injury. That would begin immediately after the complete transection of your cord. Then, it occurs in varying degrees after your partial transection. It occurs after a spinal cord contusion or compression and ischemia, the exact cause of which is unknown, but these are the etiologic factors related to which. Okay, now, when I say spinal shock, it would involve the loss of motor function, even the tendon reflexes, and including the autonomic function. I said earlier immediately, or it would begin within 1 hour of the injury and may last from a few minutes to several months. Okay, recall earlier that we are expecting this to last for 6 to 8 weeks. Okay, earlier we have mentioned that we are doing or we are able to assess the actual degree of damage of the patient after 6 to 8 weeks. Okay, the reason for that is that your spinal shock could last up to 6 weeks. It would end slowly with gradual reappearance of your reflexes. So what happens after an impact to your spinal cord is that your patient will have series of signs and symptoms. These series of signs and symptoms may be related to your spinal shock and not to the actual spinal cord injury itself. For that's why we need to wait for the spinal shock to wean off. Okay, that would be after about 6 weeks for us to assess the degree of damage to the spinal cord of our patients. Then, we have the early symptoms of your spinal shock. So, a patient with spinal shock would have the decrease of the vital signs, blood pressure, pulse, respiratory rate, and temperature. Your patient would appear warm, pink, dry skin. And then immediately, again, as I have mentioned, there is absence of reflexes. So, if you'll be assessing your deep tendon reflexes, there will be no reaction, flaccid paralysis, loss of skin sensation below the lesion. Okay, so lesion again is the damaged part. Now, within 2 days post-trauma, you would expect that there is paralytic ileus. So to assess for paralytic ileus, you need to check for the bowel sounds. So once there are no bowel sounds, okay, you would suspect presence of paralytic ileus. For urinary retention, okay, you need to assess for bladder distension, which could be found on the hypogastric region, and then of course oliguria. Okay, the bladder is distended, there is no urine going out of your bladder. Okay, so oliguria or decreased amount of your urine. Then, within 7 days, you would expect the occurrence of your stress ulcers. Okay, so stress ulcers, there is diminished muscle tone and strength, pulmonary infection, especially if we're talking about the involvement of C1 to C4. Why? If there is involvement of C1 to C4, diaphragmatic excursion and diaphragmatic movement is minimal. Then, infection is also at increased risk. Paralysis could either be spastic or flaccid, and then your patient may already manifest with paraplegia and or quadriplegia. So when I say paraplegia, again, that would usually refer to the paralysis of your lower extremities. Quadriplegia, both your upper and lower extremities. So when I talk about lower paralysis or lower extremity paralysis, we're referring to a lower spinal cord injury that would usually involve either your thoracic or lumbar. But if I'm dealing with a quadriplegic patient, that would usually involve your cervical and then the upper thoracic. Then you have venous thromboembolism. Venous thromboembolism is also one of the complications of your spinal cord injury. So, a patient with spinal cord injury is at risk for venous thromboembolism because, of course, of immobility, flaccidity, and then decreased vasomotor tone. Since your patient is not moving, there is an increased risk for formation of your thrombus. And later on, okay, that may develop to deep vein thrombosis, and then if it will be dislodged, the risk for pulmonary embolism. Okay, that's why you need to have your patient on passive range of motion exercises, and then the application of TED host with precautions. Okay, so TED host this time would have precautions because it could trigger your autonomic dysreflexia also. Okay, later on we'll talk about your autonomic dysreflexia. So Here it is, autonomic dysreflexia. So when I say autonomic dysreflexia, it is an exaggerated autonomic response that occurs in clients with spinal cord injuries at or above the level of T6. Okay, so again, at or above the level of T6. It is considered a neurologic emergency. Okay, so it is a neurologic emergency. The diagram here at the right would help us explain your autonomic dysreflexia. Let's talk it later. Now, so it is referred to also as autonomic hyperreflexia. It is seen after recovery from spinal shock. Okay, so your autonomic dysreflexia is very common after recovery from spinal shock. It would result from the lack of control of your autonomic nervous system. Again, the cause is lack of control of your autonomic nervous system. Now, what are the triggers of your autonomic dysreflexia? So, autonomic dysreflexia is a reaction. It is a hyper reaction of your autonomic nervous system. So, full bladder is the most common cause of which. So, if your patient would have full bladder, it would trigger some series of responses. Then, constipation or fecal impaction. Constipation or fecal impaction would lead to dilation of your rectal area, intrauterine contraction, pressure, ulcer stimulation, and then the presence of your ingrown toenails. Now, let's try to understand what happens in your autonomic dysreflexia. So once those triggers would occur, for example, bladder distension, distension of your lower part of your descending colon, what would happen is that it would trigger your efferent stimulus. Okay, so it would trigger your stimuli. It would trigger your nerves here, but due to the injury on the T6, okay, the reaction or the stimulus could not go up the spinal cord and go towards the brain. So what happens here is that there will be a massive sympathetic response. And because of the massive sympathetic response, it would trigger a massive vasoconstriction. Okay, remember vasoconstriction. Since there is vasoconstriction, your blood pressure is expected to increase. Okay, and because of that increase of your blood pressure, what occurs is that your vagus nerve, okay, your vagus nerve would try to counter it using your parasympathetic response. Other than that, once your blood pressure has increased, your baroreceptors, especially the baroreceptors located in the carotid artery, would be triggered. Recall the function of your baroreceptors. So your baroreceptors, as the term implies, baro is pressure. It detects the presence of pressure receptors. So pressure receptors. These are receptor areas that would elicit the release of substances that would decrease your blood pressure in case there is an increase of your blood pressure. So again, hypertension. So to counter that effect, your vagus nerve and your baroreceptors would do something to decrease the blood pressure. Okay, so they would send the signal going towards your brain. And then what would happen is that there will be a reflex bradycardia, so your patient would have decreased pulse, and then the descending signals will also be blocked. Okay, that decrease of pulse or that signal to decrease the pulse and to do the vasodilation could not reach the lower part of your system, okay, or could not reach the lower part of your body because of the damage on T6 or higher. Okay, so again, what happens in your autonomic dysreflexia is that there is an exaggeration of sympathetic response, which is triggered by the stimuli I mentioned earlier. So one trigger is the enlargement of your bladder or bladder distension. Okay, due to that enlargement of your bladder, again, it would trigger a lot of sympa response. And then because of a lot of sympa response, that will be a systemic sympa response, okay, your parasympa would try to compensate. And because of the compensation of your parasympa, okay, there will be bradycardia. Okay, now, if this would not be managed, your patient would manifest with seizure. It is possible that your patient would have CVA or stroke, and then your patient will be at risk also of myocardial infarction. That's why your autonomic dysreflexia is considered to be a neurologic, okay, it's a neurologic emergency. Okay, so it's a play between your sympa and parasympa exaggeration. So, what are the assessment findings? Mentioned earlier that there will be severe hypertension. And again, that is brought about by the massive sympathetic response and vasoconstriction. There will be bradycardia because of the compensatory response of your baroreceptors and then your vagus nerve. There will be pale, cold, dry skin below the lesion. Why? Pale, cold, and dry. Because if you can recall, below the lesion, you would have your vasoconstriction. Okay, because of the sympathetic response, there is vasoconstriction. Because of vasoconstriction, there is no blood going towards the periphery. Okay, there is also blurred vision. Okay, blurred vision, hypertension. Okay, there will be presence of your goosebumps or your piloerection. Then your patient would also be feeling nauseated. Other than that, okay, so here are the treatment that we can do for a patient with autonomic dysreflexia. You need to elevate the head of the bed and remove your TED. Okay, so what I'm referring here of your TED is your TED hose stockings. So why? It is possible, okay, it is possible that your TED hose stockings will be able to irritate your sympa system due to the pressure. Okay, due to the pressure that it places to our legs or lower extremities. So, your tight clothing and your TED stockings could possibly irritate the nerves that would thereby trigger your sympathetic cascade also that would lead to vasoconstriction. So, we don't want that to add on to our problem here on vasoconstriction. Of course, we need to assess BP and assess for stimuli. If you are suspecting that your patient is having autonomic dysreflexia, first thing that you need to check is bladder distension. And then after that, you need to check for bowel distension. Because these are the triggers of your autonomic dysreflexia. You'll be giving antihypertensives as ordered, okay? Because one of the causes of all of this reaction is the increase of your blood pressure. So you have your hydralazine, okay, that would be given IV, so common brand for which is aprisoline. Then you have your nifedipine. So your nifedipine is a calcium channel blocker. It is advisable that your patient should avoid flexion, extension, and rotation of the neck. The neck should be maintained in a neutral inline position. That is to ensure that there is adequate blood flow going towards your brain. Okay, and then at times the neck is also immobilized. Okay, so you need to secure the head by placing a belt tape across the forehead and secure it to the rigid board. And you need to maintain the patient in supine position. Okay, so this is our anatomic position. This is to ensure that adequate blood flow would be going towards different body parts. Then, you have your jaw thrust maneuver. Okay, earlier I have mentioned that when your patient have an airway problem, you actually have two options. One of your options is your head tilt, chin lift maneuver, and then you'd also have your jaw thrust maneuver. So class, in a patient who had fall or vehicular accident, the best way for you to open the airway is your jaw thrust maneuver. You cannot do your head tilt chin lift because of the head tilt part there. You are not supposed to tilt the head if you are exploring the risk of spinal cord injury. Why? If there is risk of spinal cord injury and then you do the head tilt, okay, you're sending your patients 6 feet below the ground. Then you have your diagnostic test, still X-ray. Okay, so X-ray could visualize your fracture, deformity, and displacement or hematoma of the vertebrae. Okay, by the way, this picture here at the right side is an MRI picture. Okay, this is not an X-ray image, so this is more of an MRI. Okay, then you also have your CT scan and your MRI. So you know that between the two, it will be your MRI that will be able to give more details. Okay. However, if you would want to see the gross appearance of this fracture, it will be your X-ray that could help. Okay, gross as in the big appearance of your bone. However, if you want to see what part of the spinal cord is possibly impaired, okay, if you want to see the part of the spinal cord that is possibly impaired, you need to do your CT scan and your MRI. Okay, so MRI would give you more detailed image. Then you have your electromyography and then your evoke potential. So we've been talking about electromyography and evoke potential. So electromyography, it's trying to evaluate the signals in your muscles, and it is an invasive procedure. Okay, as you can see, class, here are the signals of the muscles. No? So these are the neural firing that you can find in the muscles. So this will be able to locate the level of spinal cord injury. So we are looking into the parts innervated by the spinal nerve that is assumed to be damaged. And then ABG is also done to establish your baseline. Okay, because a patient with spinal cord injury could possibly have your respiratory depression, respiratory arrest secondary to poor innervation of your diaphragm. Hence, ABG needed. Okay? Now, for the pharmaco, you need to give corticosteroids to this patient who is at risk of autonomic dysreflexia. Why? Your corticosteroids will be able to decrease or control the edema of your cord. Vasopressors. Your vasopressors are used in immediate critical care to treat bradycardia and hypotension. Okay, so you need to be careful whether the problem of your patient is hypertension or hypotension. Take note that your vasopressors is indicated for hypotension. Then you have your antispasmodic agents and then your muscle relaxants. So your antispasmodic agents or your muscle relaxants, such as your baclofen, okay, you also have your dantrolene sodium, are given to control muscle spasm and pain. Now, one thing, if you're given your dantrolene sodium, it has a possibility of causing dizziness. So you need to ensure that you have done a comprehensive neurologic assessment before you would give these medications for you to ensure that your patient is not having any other problem. Okay, such that by the time that your patient is already dizzy, you have already done your complete neurologic assessment. Okay, so other than that, you'll be giving your analgesics, your NSAIDs, of course, for the purpose of pain. Then you have your H2 antagonist. Recall earlier that we have mentioned that this can prevent your stress-related gastric ulcer, which is a common complication of your spinal cord injury. So anticoagulants, you may be giving your heparin or warfarin to prevent thrombophlebitis. Usually, for the decreased risk of bleeding associated with the use of your anticoagulants, we are using your low molecular weight heparin. Okay, then we'll be giving your stool softeners. We know our patient not moving. Our patient may need aid for defecation. So we need to give stool softeners, okay, to aid our patient on the process. And we don't want autonomic dysreflexia to be triggered, hence the use of your stool softeners. Then, for stabilization and immobilization, this is spinal cord injury in general. Okay, so for us to stabilize our patient, we need to use your immobilization devices. Okay, so here we have your head halters, then we have your tongs, okay, which are used to immobilize the head. What is the purpose? Why do I need to immobilize the head? So earlier we mentioned that during the accident, when you are responding to the accident, you need to immobilize the neck because you would want to ensure that you will be preventing spinal cord injury or spinal cord damage or further aggravating it. So for that reason, class, you need to immobilize. Okay, now when you are immobilizing, this one may be good, your cervical collar may be good. However, in the long run, you need to have more stable, okay, immobilization devices. Okay, now these immobilization devices may last for long. Okay, may last for long. So your cervical collar is here, okay, also referred to as your neck brace. Then class, you have what you refer to as your cervical traction. So even though that this equipment is grabbing through the head of the patient, class, these are intended to immobilize the spine. Okay, so the main the main premise the main premise behind your traction is to have a counterweight that would ensure immobilization of the bone. So your patient needs to be maintained on immobile. Let's try to differentiate between these immobilization devices. Okay, so the first one is your cervical traction. As you can see, this is a head halter with weights. Okay, these are the weights. Okay, the one here in the red bag are the weights. So the weight is actually determined or computed by your neurologist. Okay, in this case, a neurosurgeon or maybe a spine surgeon. Okay, then you would have your Gardner-Wells tongs. Okay, which would involve the application of your pins to the skull approximately 1 centimeter above each ear, and the weights are attached to the device. So look at the appearance of your Gardner-Wells tongs. Okay, so it's like a U-shaped device. Okay, so the screws are inserted through the skull of the patient, approximately 1 cm above each ear. Now, you need to ensure that this part of the patient is properly cleaned because that may result to infection if you are not able to clean it properly. Then you also have your Crutchfield tongs. So your Crutchfield tongs are inserted through the holes made in the skull and attached to weights. Okay? Obviously, that would be applicable for your all of your traction devices. However, the difference of your Crutchfield tongs compared to your Gardner-Wells is that, notice here. Okay, so in your Crutchfield tongs, they are not in U-shape. Instead, this part here could be adjustable, so depending on the size of the head of your patient. Then you have your these are the general principles for traction. So traction force is exerted along the longitudinal axis of the spine with the neck in neutral position. So class, as you can notice, the traction is expected to pull the head of the patient for the purpose that the spinal column will be pulled. This pulling mechanism of your spinal column, okay, is hoped to immobilize your spinal column. Now, the counter traction or the counterweight of that will be the weight of the patient. That's why it is not advisable that your patient will be moving or your patient's position will be changed because the amount of traction that will be applied will be varying. Okay, recall the principles of your traction in your physics. So this is the application of the computation of your traction or counter force when it comes to our nursing care for our patient. So the amount of traction would depend on the size and then the degree of your fracture. Then, the reduction of weight would usually occur after the correct alignment has been restored. So how would we know that there is already correct alignment? So we are doing, okay, the physician may be doing x-rays and then neuro assessments. If you are dealing with patients who are using tractions, take note that the weights should hang freely. Okay, it is not possible that this weight is lying on the floor because it would defeat the purpose of it being a weight for your patient. Okay, if it's on the floor, it could not do the pulling mechanism towards the spine of your patient. So again, the weight should be hanging freely, not on the floor. Okay, so you have your halo device. The halo device is also referred to as your halo external fixation or your halo vest. This consists of small stainless steel halo ring fixed to the skull by pins. So there are 2 pins in the frontal bone and then there are 2 pins in the occipital bone. Okay, so the purpose of which is of course to immobilize still your neck. Okay, to immobilize your cervical spine. So it may be used initially with a traction. So again, there are 2 pins, the 2 pins in the frontal bone and then the 2 pins in occipital bone. There are cases wherein additional pins are added depending on the case of your patient. Okay, so this is another example of your halo traction. Okay, term halo because of the circular frame there. So the metal frame would connect the ring to the chest and attach to a rigid plastic vest that would line with a sheepskin. So why a sheepskin? Just for the comfort and to prevent impairment of skin integrity. It would provide immobilization of your cervical spine while allowing for early ambulation of your patient. Okay, so you are preventing the complications which are deep vein thrombosis, okay, your pulmonary embolism, and at the same time, you are allowing your patient to have the cervical spine immobilized. Then you have your striker-Turner frame. So class, your striker-Turner frame is an example of a special bed. No? Okay, another example would be your circoelectric bed, which would maintain body alignment, while at the same time your patient could be rotated or repositioned. Okay, so this allows for repositioning, preventing your pressure ulcer, and at the same time your patient is maintained as a single unit. Okay, so this is an example of your circoelectric bed, and then you also have your rotorest bed. Okay, again, the purpose is to prevent pressure, ulcers, and at the same time, the patient is considered as a single unit, meaning the entire spine is immobilized. Okay, so surgery. Surgery is done if there is compression to the cord, if there is fragmentation or unstable vertebral body, if there is a wound that would penetrate the cord, or there is vertebral body in the spinal canal, or your patient would have deteriorating neurologic status, okay, which would indicate that there is possible impingement of your spinal cord or the blood supply may have a problem. A surgery that can be done, okay, for your patients with vertebral collapse, okay, or vertebral problems is your spinal fusion. So your spinal fusion would involve the insertion of your metal rods to fuse 2 or 3 vertebral bodies. Okay, so that allow for immobilization of that part, that also allows for healing on that part, and that also allows for the development of the disc or intervertebral disc between the bone spaces. Okay, then you also have your laminectomy. Your laminectomy would involve removal of a part of the vertebral lamina to relieve the pressure on the spinal cord or nerves. Okay, so as you can see on the picture, there is removal of your lamina. So class, your lamina is on this part of your spinal column. Okay, or is under part of this of your vertebrae. So that is removed and with the hope to relieve the pressure. Okay, to relieve the pressure on your spinal cord or spinal nerves. So as you can see, there is compression here. Okay, there is compression on this part, but after laminectomy or the removal of the lamina, the pressure is relieved. Okay, so that's laminectomy. Okay, the spine surgery that we've been talking about. Then nursing care. So for a patient with spinal cord injury, priorities will be impaired physical mobility. Of course, ineffective breathing pattern will be more of a priority if you're talking about higher spinal cord injury. By higher, I'm talking about cervical problems and upper thoracic injuries. Then you have altered urinary and bowel elimination pattern and even your sexual dysfunction, and then impaired skin integrity. That's why you need to turn your patients. Okay, you need to place your patients on special beds for them to be rotated and for you to prevent the occurrence of pressure ulcers. On the succeeding topic, we'll be discussing about your herniated vertebral disc. Thank you for your attention.